want to protect the people.
What are your building stock? Please.
Yeah, I can fly.
Raid is complete.
Tell you what, throw a little hot rod red in there. Good luck keeping up.
Want to protect the people.
Good morning, esteemed panelists and fellow delegates. My case is titled, it's a case of common carotid stenting in a case of Marfan syndrome. This was a 32-year-old male gentleman. He is a known case of Marfan syndrome. He presented in cardiac failure about an year back due to aortic arch dissection and was detected to have severe aortic regurgitation at the same time. He underwent aortic valve replacement with an aortic arch graft about a year back. After that, he was kept on warfarin to maintain the INR about 2.5, and the latest INR before he presented to us was 2.7. He also was on Remipil 2.5 mg per day and atenolol 12.5 mg per day. He presented this time with a 2-week history of neck pain on the right side and recurrent history of motor and sensory TIs in the right MC territory, consisting of paresthesias in the left side of the body as well as intermittent left upper limb weakness. He had around 7 to 8 episodes before he presented to us. The CT brain did not show any acute infarcts. The CT angio showed dissection involving the innominate and right common carotid up to its bifurcation, causing about 60%, 70% stenosis. He was already on anticoagulants, so an antiplatelet was added, and the TIs persisted for about a week, even after adding icosprin 150 mg per day. These are the images. You can see the aortic arch. Here's aortic arch with the graft, aortic wall, and you can see the innominate dissection. There is a false lumen in the innominate dissection with a very narrow true lumen left behind. And also there was severe stenosis of the right common carotid artery in the mid and distal segment of the right common carotid artery. You can see this highly redundant ICA, elongated and redundant ICA, and the intracranial circulation was normal. Since he was having TIs in spite of what we thought is adequate medical treatment, he was considered for proximal right common carotid stenting, followed 2 weeks later by mid and distal right common carotid stenting. We felt that it would be safer to split the procedure into 2 parts. The patient was shifted from warfarin to injection enoxaparin, 0.6 ml BD for 3 days prior to the procedure. An 8 French guiding was deployed in the innominate. 014 guide wire was deployed in the proximal right ICA. A 6 mm spider distal protection device was deployed in the proximal right internal carotid artery. A 10 mm into 40 mm precise self-expanding stent was deployed in the proximal CCA. You can see that the stent is not fully opened up, but I did not do any post-dilatation deliberately because I knew that when the patient would come for the second procedure, the stent would have opened up. He was discharged on icosprin 150 mg per day and enoxaparin 0.6 mg BID. He was taken up for the second stage of the procedure, and true enough, I found that the right common carotid stent had expanded further, as these self-expanding stents always do. You can see that the false lumen is no longer seen. Again, an 8 French guiding was deployed in the innominate, a 014 guide wire in the proximal right internal carotid. Again, a 6 mm spider in the proximal ICA, an 8 by 6 by 40 Protege self-expanding stent in the distal common carotid, also going into the proximal ICA. Then overlapping with this distal stent, a 10 by 40 mm precise stent in the mid common carotid artery, overlapping with the first stent. Post-dilatation was done with a 6 by 20 angioplasty balloon at 2 or 3 places for the residual stenosis. The post-op was uneventful. Fortunately, he did not have any hypertension. He was discharged on icosapent 150 mg per day and enoxaparin. And 1 week later, he was shifted to warfarin. You can see that the common carotid and ocular and skeletal systems. Dissection of various arteries is common. Isolated dissections of the cerebral arteries is relatively uncommon. And patients can present with either traumatic or spontaneous dissections. The carotid artery dissection is usually due to the extension of aortic dissection, but in this case it was primarily, since probably the aortic arch had already been grafted, the patient presented only with dissection of the extracranial innominate and the carotid artery. Thank you.